You know, you hear when you go to your pediatrician for your child's 1-year-old appointment, how many words are they saying?
Most of the studies tell us that by the age of 1, children should at least understand 100 words. They're not always using 100 words in their vocabulary. Children are going to use words that are not correct. They're going to mispronounce things at times. But if they get to age 3 or 4 and you're only hearing them use maybe 1 or 2 words, then it might start to be a concern.
And early intervention's key, because if a child cannot communicate, it leads to behavior problems and it's frustrating for them.
It's because they're not able to tell us what's wrong and they're trying to say something is wrong. Modeling the appropriate language for our children is important. I mean, they're like a sponge. They're picking up everything that we are saying. And so if we're using incorrect speech ourselves, then that's what they're going to pick up.
Welcome to Pulse Check, the podcast at Carolina Pines Regional Medical Center. My name is Anna Tingen, and I will be your host today. Today with me is Miss Brandy White, our Director of Speech, and we're going to talk a little bit about a service that people don't fully understand until it's something they need, and that is speech therapy. Thank you so much for being here today, Brandy.
Yes, I'm happy to be here.
First of all, Brandy, I want you to tell us a little bit about yourself and your background and what led you to wanting to be a speech therapist.
Well, I'm from Hartsville originally. So when I was going through school, I wasn't sure what I wanted to be. Just like anyone else, I had lots of different dreams. But my mom and I got to talking one day. And when she was a child, she was hearing impaired. And it was like 3rd or 4th grade before anyone realized that she was missing out on most of what other people were saying. She was really quiet. She just kind of sat in the classroom, did her work, didn't speak a lot. And one of her doctors realized that she was having trouble hearing. And so they started a speech therapy program for her. And once they realized that the hearing was the problem and they were able to correct that, then she started participating more in conversation. And so it just got me thinking that, you know, there's so many children that sometimes we might miss those things and they're missing out on that communication with others.
Yeah. So tell me, where'd you go to school?
So for my undergraduate degree, I went to Columbia College in Columbia, South Carolina. My undergrad was in speech therapy and education. Then went to get my master's at the University of South Carolina in Columbia, and my master's was in communication disorders.
Okay. And then you came back to Hartsville. Did you work private practice before you came here?
I started out my career, I was actually working in the school district. I worked in the school district as a speech therapist there for about 4 or 5 years. Then I transitioned to the nursing home, and I worked there for 14 years prior to coming here.
Okay. Why is speech therapy so important?
So I think that speech therapy is important because we thrive off of relationships, right? We were made to have relationships with
human
others.
Interaction.
Right. And if we're not able to communicate with others, just like anyone else, it makes it difficult for us to build those relationships. Children shut down, adults shut down. They find themselves not wanting to leave the house, not wanting to participate in life. And so if I can provide a way for them to communicate and build relationships with others, I just feel that it makes them more successful and they're more confident.
Yeah.
And if you're more confident, then you want to participate in life.
And building confidence is key.
Yes.
Especially at a young age.
Absolutely.
Tell us this. What is the most rewarding part of your job as a speech therapist? Especially because you see so many different ages.
Right. And so I think the success is different at different levels, right? So if I'm working with an infant that's unable to eat, I had a patient recently who he was going to MUSC. They were thinking they were going to need to put an NG tube in because he wasn't eating. He was 7 months old. And he is now eating a regular diet. He is a little over a year old. They never had to place the NG tube.
That's wonderful.
So, I was able to work with the family closely to determine they were trying multiple different things with the patient. And so he was kind of warding off all food, right? So we just kind of started a slow process where we would introduce one new thing to him. He actually wanted to be more independent than they thought he would because he was much smaller than most children his age. And so they were actually treating him like his size, right? So they were treating him like he was 2 or 3 months old because he was the size of a 2 or 3 month old.
Right.
But he was already 7 months old. So he was ready to try to feed himself. And so that helped too, just being able to work with the family so that he could feed himself. But I think, as patients get older, seeing them be successful and not afraid to read in front of a class because they don't have difficulties with their sounds. Most kids, by the time they hit 3rd or 4th grade, they're embarrassed by that speech impairment.
Right.
Right. And they're scared of what their peers are going to say. And so if you can make it where you can see them willing to get up in front of a classroom and speak, then you've won, right? I mean, because they're successful. And that's what we're hoping for.
And you see them build that confidence.
Absolutely.
Back up.
I see that a lot with patients who stutter as well. I had an older patient, he's middle school, and he did a presentation last week in school.
Oh, that's wonderful.
So, he sent us a message because we actually have discharged him now, but he sent us a message just to say I was able to get up and do that, right? And so I think that is very successful.
Yeah, that makes it worth it.
I think when I look at my older population, sometimes it's just being able to eat that piece of pizza that you wanted that you haven't been able to eat for months, right? We love food, right? We like what it looks like. And if you're having to eat food that looks like a baby food as an adult, it can be very discouraging. Right. And so if you can get them to eat that one thing that they've been wanting to eat, even if you're having to cut it up for them, just to see them smile about that, I think, makes everything worth it.
Yeah. Okay. So a lot of people assume speech therapy is for children, mostly a pediatric thing. At least I did. And so now I have learned that a lot of inpatient services are for our older generation or our older population. So tell us a little bit about the inpatient services. I know there's some cognitive things. They have to relearn how to do certain things with the muscles in their face and their mouth. Can you tell us a little bit about that?
Yeah. So most of the patients that I get inpatient referrals on have had a stroke. So therefore they have a weakness on one side of their body versus the other. And we think about people not being able to move their arms and their legs because we can see that. But in reality, when someone has a stroke, it also affects their muscles of their swallowing. And so it affects their neck and their face. When we swallow things, we worry about chewing. And so we think about, if we're not feeling one side of our mouth very well, or if those muscles aren't working, the food could get stuck.
They could choke.
Yeah. And so when they go to swallow their food, when it gets into their throat, it can get stuck, and they do, and they choke. And then they're just at risk for it to go into their lungs, which can cause many other issues like pneumonia. Yeah. So we go in and just try to assess, where the deficits are, so that we can try to strengthen those muscles.
So if a patient has a stroke and they come in through the ER, for example, how soon are you involved in the patient care after the diagnosis of a stroke or they've been admitted? Do you go to the ER or do you wait till they're in a room? What's the process?
I typically receive the referral while they're still in the ER. We do typically wait for them to get to their room because there are some interventions that they provide in the ER that they suggest speech therapy wait like 24 hours before they address that patient because it actually can help them recover some of the muscles if they have some of those things in the ER. And so I usually try to wait for that to be able to take action. Then I usually go in and see. If the nurse notices that they're really coughing and choking on anything they give them, we may go in a little sooner.
Okay. So what's the typical, how long does a patient see you after having a stroke? Just average?
So it depends on the severity of the stroke.
Uh-huh.
Sometimes if it's just we get some stroke alerts in the ER, and then once they come up to the floor, they start to regain some of the strength in their muscles, and they may not need us as long. So we might just go in and assess to see what diet is appropriate, like if they need a softer diet or if they need their liquids thickened a little bit at first until they regain some of that strength. If it's more massive stroke, we could potentially be in for several days until they're discharged to the next setting, to a skilled nursing.
Yeah.
Speech therapy would typically probably follow them at that skilled nursing or rehab as well.
Brandy, considering you see patients of all ages, what are the top 3 things you see patients for?
So in the younger population, school age children, a lot of times I see speech sound disorders. And sometimes there's a diagnosis that can lend way to that, but that doesn't mean that we can't address it. And sometimes it's just a weakness. So like maybe their muscles in their mouth are just not working like every other child. They haven't used their tongue as much as they should to lift it for an R or an L. And so it's just kind of staying in the bottom of their mouth. And so sometimes it's just awareness, right, of those muscles. Maybe they're not putting their lips together to make a P sound.
So sometimes it can be an easy fix.
Yes, sometimes it can be a very easy fix. And even with children that have a diagnosis, sometimes it's just figuring out a way to help them communicate so that they're less frustrated. So it may not be communicating like you and I do, but it's finding some form, because we thrive off of communication.
Right.
Even with my older population, when I run into like a stroke patient, if we're working with swallowing, it can be muscle weakness. But sometimes it can also be that they're having trouble finding their words and they can no longer communicate with their family like they could before. And so it can be the same thing. We're just finding some way for them to communicate with their spouse or with their children.
I know that's got to be frustrating, but the work you do can be really rewarding for these patients and these families.
Absolutely.
Okay, so most recently you were certified in a fees study, correct?
Yes.
Tell me more about that. I have no idea what that is.
So it is a diagnostic swallowing assessment. When I assess at a bedside, I can look at a patient, I can see their muscles, I can feel their swallow, but it can't actually see inside their throat.
Okay.
And so the fees allows me to do that. There's a modified barium swallow study, which requires a radiologist, and the fees allows me to do that without a radiologist. It also allows me to go up to the patient's room. So if they're in the ICU and they're in a pretty severe condition, I can go to them, that we don't have to try to bring them to me. The study actually drops a light in through their nose with a camera. And it drops it down above the swallow so that when they swallow, I can actually see inside their throat to see if there are any deficits or if there's any food hanging out that, we might not pick up just on a bedside.
God, I bet that's great for outcomes, though.
It is, because we know exactly what to pinpoint. We know exactly, what we need to target with our swallowing exercises. We also know if we just really need to change a diet, because there are times when patients don't necessarily cough or choke, but it is still going down the wrong way. And the only way we would be able to know that is with a diagnostic.
Yeah, and you do this bedside, right?
Yes, I can do it bedside. I can also do it outpatient. So, if someone's having trouble at home and they notice it and their doctor sends a referral, they can come into the office and I can do it in my therapy room as well.
Oh, okay. That's good to know. Tell me, what does FEES stand for?
So it's a fiber optic evaluation of swallow function, basically. So it's just describing the type of camera that's being used. It's a high definition camera. So it's interesting when you look in, you can see, really clearly exactly what's going on.
Oh, that's cool. So they're not put to sleep for this. It's you're
no,
wide awake.
You can be wide awake. Sometimes if a patient really struggles, like if it's really bothers them when you try to put it in their nose, there is some numbing that you can do. The problem with that is that numbing also goes down into the throat at times. And so it really can affect the actual study itself. So it's better if you don't. But yeah, so we can just do it without anything.
That's neat. Now let's talk about pediatric services that are offered through the hospital and through your speech department. What's the process look like to get your child into speech here? Do they need a referral? Do you have to assess them? Tell me about that.
So really the first step would be getting their primary physician to send a referral to us. Just because we have to get everything clear with insurance, they need that referral. Once they receive the referral, the initial evaluation is scheduled through our scheduling department. So they make the schedule for the initial eval and the family comes in with their child. I do have to then assess them to determine, where the deficits are. Is it truly a speech deficit where they're having sound errors? Or sometimes it's language, right? Like maybe they're having difficulty with expressive language. They're not talking very much, but they understand everything that's said to them. Sometimes they're having difficulty understanding and they're using a lot of speech, but they're not really understanding exactly what's going on. So there are different tests that I can give for that to determine, where the deficits are. And then I usually work with the family to try to schedule them in if they need one time a week or twice a week, and then try to work with their schedule from there on out.
Okay. Tell me this, you hear when you go to your pediatrician for your child's 1-year-old appointment, how many words are they saying? And so from a speech therapist, how many words should a child be saying at 1 or at 2? And then when is the red flag for okay, I think my child might need speech therapy?
So most of the studies tell us that by the age of 1, children should at least understand 100 words. Where that becomes confusing is they're not always using 100 words in their vocabulary. And so I usually take that same, if they're 2, we're expecting 200. You have to use experience sometimes. Children are going to use words that are not correct. They're going to mispronounce things at times. And that's pretty typical. But if they get to age 3 or 4 and you're only hearing them use maybe 1 or 2 words, then it might start to be a concern.
Yeah.
There are different standards for different ages. But if my child got to age 3 or 4 and they weren't using too many words, or I didn't understand anything that they're saying.
Right.
As parents, we understand our children even when they have, mispronunciations. But there are times when I have parents come in and say, I don't know what my child is saying. They're 4 years old. There are words coming out, but I don't understand anything.
Yeah.
And so that's usually a pretty good red flag that, maybe they have some things that are not really developmental and that we might need to address, that they would need some intervention.
Yeah. And early intervention's key. I mean, because if a child cannot communicate, it leads to behavior problems. And I've read studies where biting can become prevalent in children that cannot communicate effectively. And it's frustrating for them. So early intervention is definitely key.
Right. I mean, most of the time, you think if you weren't able to communicate, right? You have to find a way to communicate. And so that does come out in hitting, biting, acting out, throwing a fit in the floor. It's because they're not able to tell us what's wrong and they're trying to say something is wrong.
Yeah.
So,
yeah. What age group do you see the most of right now?
So it's interesting. I can treat anyone from birth all the way through end of life, depending on what their deficits are. Currently, my most outpatients are between the ages of 4 and 6 years old. So they're, kind of just starting school. They maybe have a teacher that's realized, they're not able to compare with the other children that are in the same classroom. Maybe their speech is a little different from that. And so a lot of times they will bring that to the parents' attention for them to talk to their doctor.
Brandy, tell me this. If a child has a learning disability or an intellectual challenge, what can you do to help see them grow and thrive? And is speech always necessary in those circumstances?
For most of the cases, it is a good thing for them to have speech therapy. We have to determine what level they're on because obviously it's a wide range. I work with children who have no verbal language up to children that, have a lot of verbal language and their speech sounds are just the issue. If it's a nonverbal child, we try to teach them some form of communication. So we do some sign language with them.
Oh, that's great.
We also can work with them to get an iPad service that South Carolina has. Is
that just through the school? School district?
No, I actually worked with a patient this week that we got them an iPad sent in for them to get one. It's actually an application that they can do as long as they have a phone at the house, whether it's a cell phone or a landline. There's a program through that where they can receive the iPad, and then we can set it up so that it's easy for that patient to use. So that if they've only got a couple of words, we just put those things on the screen. But then if they're able to understand more than that, we can put those things on the screen so that they can ask for if they're hungry or if they...
So how's that work? Like they tap the word and the iPad says the word? That's really neat.
It says it for them. But it can be personalized for that patient based on their needs. So that's really nice because, it can be at very different levels.
That is really great. When you have a child that comes in with English as their second language, how do you approach that?
So I do not speak any other language but English. However, I try to be sympathetic to the parents sometimes because obviously they want their child to have the correct production. I don't really work on accent, but we do, especially with our Spanish speaking children, their R's are a little different from ours, right? But I work with them more if there's not an R in their vocabulary at all, right? So it's not really a modification of the R. It's if they're not using an R at all, like if they're leaving it out. I also try to let my parents know that if we work on words with the patient. So if they want us to provide the Spanish word or another language, if they will provide that for me, I'm happy to do that. But in reality, I'm from the South myself, so it would be a very Southern different accent. But sometimes they do provide words for us that we want to teach them both words. So we teach them the English word and then we teach them the Spanish word, especially if it's a language patient, not so much if it's a speech sound patient.
That's really great that you can offer that. So sign language is kind of trending with teaching your baby. Do you see that as beneficial to use with infants, like to sign more or hungry or the words that they typically cannot say at that age? Or do you see it hindering the ability to speak?
That is something that we use, especially with our patients who are nonverbal. I definitely think it's beneficial as an infant for you to teach that because it gives them a way to communicate before their words even form. It gives you a way. It doesn't even have to be official sign language. Sometimes it can just be something that we use our hands for anyway, because we use our hands to speak. But for my patients that I have that come in that are, if they're first, second, third grade and they're not speaking, we use sign language a lot. And the family sees a lot less frustration because they're able to communicate something with them. We do just some of the simple things. We do like more, open, close, things that you don't have to be very overspoken in sign language to be able to use it. Right. It's things that our families can use without knowing all of sign language.
Yeah. Brandy, talk to me a little bit about the process when a parent may think the word biscotti is cute. And we all do. We want to hold on to those memories of our children saying words like that. But then, do you notice a teacher bringing it up to parents, maybe to suggest that they come in for an evaluation or get a referral from their primary care doctor to come see you?
I think most of the time it does come from a teacher or someone, maybe even a daycare worker, because they have the ability to see multiple children in that setting. And so they can notice when there's something that's very different from the typical aging. I think as parents, we think those things are cute. And of course they are at first, but then when they last longer than just a year or two, it then becomes, the opposite side of it, right? It's no longer cute because the child may get made fun of or people may not understand what they're saying. For a parent who is concerned that their child may have some speech errors, one of the things that I always tell them is to listen for specific sounds, right? So if a child doesn't have an S anywhere in their vocabulary, there's probably a problem, right? If the only thing they say is biscotti, but they can say spoon, or they can say speech even, then they probably don't have a problem. It's probably just that one word.
Like a habit.
Yeah, it's more of, that's the way they've heard it. Another thing I think a lot of times we do as parents is we then repeat it to them that way. Like, oh, you want some spaghetti? Because we think it's cute. When in reality, if they're mispronouncing it, we should say it correctly, right? We think that we should speak to children in baby talk because they're babies, but they can understand way more than we even give them credit for.
Right.
And so if they are mispronouncing it, it would be better for us to say, oh, you want some spaghetti, so that they hear it correctly.
Right.
And then then you can start to see if they transition to the correct production of that word.
Yeah. So as a mom of 3 boys, my husband and I tried to be real intentional about creating an environment for them where their language was great. It wasn't always the case. Our middle son actually had to have speech therapy. But then when he did start to talk, your comment about they understand way more than we give them credit for is so true, because his vocabulary was huge when he started talking. So what are things parents can do at home, to create that safe space for them with the language?
I just think modeling the appropriate language for our children is important. Obviously, reading those books and them hearing those words is important, but also us speaking to them just like I'm speaking to you.
Right.
When we're talking about things that we're doing, explaining those things to them will help, but them just hearing our speech. I think sometimes we think, oh, they're just playing, they're not picking up on what we're saying, but they're really, they're like a sponge. They're picking up everything that we are saying. And so if we're using incorrect speech ourselves, then that's what they're going to pick up, right? And then they're going to be more likely. Yes.
Yeah.
If we use that correct speech and we pronounce things correctly, they're also going to pick up on that. If there's a true disorder, they may still have those difficulties, but it would be a lot easier to determine that, whether it's just a habit or whether it's truly something that needs some speech therapy to correct.
Right. So, I've seen situations where parents are dealing with a child that maybe cannot pronounce just the R or just the S. Does that equate to needing speech therapy, or is that something that typically self-corrects?
So many sounds do self-correct by a certain age. And so there's kind of a timeline. If a child gets to the 3rd or 4th grade and they still have an R, then we probably need to work on it. If I have a 4-year-old that comes in that has an R, I'm not really worried about it.
Right.
Right. And so, most of my assessments have those milestones. And so I can, have the child label different pictures, and then I can determine based on their age, do they really need speech therapy now, or do we just need to monitor for the next couple of years and make sure that they are acquiring that sound?
Yeah. Also, I think it's really important to let the community know that you have truly embraced having pediatric speech at the hospital. So it's not in a completely clinical setting. You have done a beautiful job down there of making it child friendly. And so when they do bring their children in, it's not like they're sitting in a hospital room, right?
No. We've tried to do a really good job of, making it where the children want to come in. We do have the games and we have the fun things for them to play. For my children who need a different seating arrangement, we have bean bags for them to sit on. I have some children that they just can't sit in a chair.
Right.
And so we sit beanbag to beanbag, I'm willing to get down on the floor with them if that's where they function better, right? Because we're going to see the most progress from our patients if they're comfortable, right? If they come in and it looks like an exam room, they're scared to death, right?
So
children,
sterile.
Yeah, children don't like hospitals. I don't necessarily like to go to the hospital myself. So we want it to feel welcoming. And so we really have worked on, trying to get our rooms for that space. Most of our children don't want to leave, actually. So.
Well, that says a lot about you. How I know the department has grown tremendously since it was started, less than a year ago?
Yeah. Well, so I started here in April of last year, and we really started working more on the outpatient May, June of last year.
Yeah. So how many therapists are there total now?
So I've just hired my 3rd therapist. We have a lot of patients that really need afternoon hours. And so it'll be nice for us to be able to book those patients a little bit more in the afternoon because they want after school time.
Yeah.
So
that's great. That's great. Well, Brandy, thank you so much for being here today and sharing with our community what you and your team do at this hospital through speech therapy. We're very fortunate to have you here, and I'm excited to see how this program continues to grow.
Yeah, thank you for having me. I've really enjoyed it.
Yep. And thank you for tuning into Pulse Check.
Thanks for listening to Pulse Check. If you enjoyed this episode, be sure to like, follow, subscribe, and share it with someone who might find it helpful. Your support helps this podcast reach more people in our community. Pulse Check is a production of Carolina Pines Regional Medical Center. Special thanks to our producers Hannah Cadell and Anna Tingen. Audio, video, and editing services by Seth and Grayson Johnson at Lockwood Studios. All content is for educational purposes only. We do not intend for the content to be a substitute for professional medical advice, counseling, diagnosis, or treatment. Our content doesn't engage visitors into a professional relationship. We'll see you on the next episode of Pulse Check.